Good afternoon. Thank you for tuning into Best Health Community virtual class entitled Oh My Achy Knees. Best Health is a community wellness outreach program of Wake Forest Baptist Health, and we offer a variety of virtual health and wellness seminars and events to help you to live a healthier life and stay on top of the latest advances in medicine. To stay informed of upcoming classes and e-newsletter subscription, please visit www.wakehealth.edu/besthealthcommunity. Best Health
It's just not going to see us both.
recorded seminars and podcasts located under the Best Health video library and Best Health podcast on the main Best Health Community website. If you all would, please put your mics on mute and goes off until we hear further from Dr. Steve Lucey, and we will move forward on with Dr. Steve Lucey. Thank you all for attending.
Thank you. Yes, if you could put your screens on mute, there should be something on the lower left-hand corner of the screen that you can tap to mute, and I think everybody has. Thanks for joining this afternoon. This isn't something that we would be doing a couple of years ago, so it's a really interesting and creative way to try to engage and learn and communicate. So Wake Forest certainly has done a great job, embracing the new era of COVID and trying to help our community. So I appreciate Wake Forest very much. So my name is Steve Lucey. I am an orthopedic surgeon. I live in Greensboro, have been practicing in Greensboro for 20 years. And I trained at Wake Forest many years ago, and I've continued to be in relationship with them most of my professional career. Of course, bounced around for my training for a lot of years. But my specialty is actually knee surgery. I have done 2 fellowships, one in sports medicine and one in joint replacement. And so my practice is called Sports Medicine and Joint Replacement of Greensboro, but I am completely under the Wake Forest banner here in Greensboro. I also have a hip surgeon that comes into the office from Wake Forest. I was a shoulder surgeon, but my professional world revolves around the knee. So good title for me to talk. So when when they asked me to speak about achy knees, specifically aching, whether it's knees or back or fingers or whatever, aching knees tends to symptom of arthritis. So while I see lots and lots of things in the knee, from young sports injuries to complicated knee surgeries, the most common thing that I see by far is arthritis in the knee. And that could be a 40-year-old that is just beginning to get arthritis, or it could be an 80-year-old that has very, very bad knee arthritis. And I see everything in between. So first of all, just to make sure we're all on the same page, the definition of osteoarthritis, of course, there's other forms like rheumatoid and other things like that, but the definition of osteoarthritis is that the shiny cartilage on the end of the bone, which we call articular cartilage, is wearing away. So if you eat a chicken leg or something and you see that pearly white ball on the end of that drumstick, that's articular cartilage. And we have it in all of our joints, whether it be fingers, knees, whatever. And as that wears away, that is the definition of arthritis. The nerve endings are in the bone. And so as long as we have that shiny articular cartilage covering the bone in our joints, we have no pain. As it wears thin and there's some bone exposed, we have some pain. And then when you've heard bone on bone, you have nerves rubbing on nerve endings, and that is very, very painful. That's severe arthritis. So that's what arthritis is a wearing away of that cartilage. There's kind of a progression of treatment of arthritis, obviously depending on how severe it is and how long the patient has been dealing with it. Kind of the first step that we enter into, and I have some props. I thought it'd be easier to do that than some PowerPoint and share my screen. So there's 2 medicines that I generally recommend. One is glucosamine. This is a product that happens to be sold at Costco. It's a great brand. It's actually made in South Carolina. It's pure. a lot of the glucosamine products that you would find on the shelf at a grocery store or a big box store, they don't have to be 100% glucosamine conjoined. There can be lots of filler products to make it cheaper, and then they don't work as well. This particular product has been studied very well. It's very safe. It doesn't have side effects. It has about a 60% efficacy, meaning it works in about 60% of the people that take it. Most of my patients describe the benefit as it making their joints feel less stiff and having some degree of less pain. So that's glucosamine and control. And just make sure you're getting a reputable brand. And I would recommend this one from Costco. It's also sold at Walmart. There's a whole bunch of other ones sold that you really have to be careful what you're buying. And then some kind of an anti-inflammatory. This is my own personal vial of ibuprofen because it works well for me. But it's very dependent on the patient as to whether it's ibuprofen or diclofenac or Celebrex or meloxicam. There's a lot of anti-inflammatories, but if the glucosamine doesn't work, then the anti-inflammatory is the next thing that we use. The problem with anti-inflammatories is not that they don't work, because they actually work closer to 80 to 85% of the time, but there also is between a 10 and 15% chance of having an ulcer if you take them daily. And so my strategy is to use the glucosamine so that you only have to use the anti-inflammatory on weekends, or just not all the time, not perfectly every day. So that's pills. There's lots of things that patients bring up to me, like turmeric and curcumin, and I could go on and on and on. And they're all fine. I don't have an issue with any of them. But there's no science behind those. There's no studies, and so they're fine as long as the patient tolerates them well. The next kind of group of treatment after pills would be shots. And there's two very basic types of shots. All of you have probably heard of cortisone shots. Cortisone works very, very well. It's a very powerful anti-inflammatory. But the general rule is you can only have 4 shots every year. So 1 every 3 months. Otherwise, it can do damage to that cartilage you're trying to protect. It can make the bones soft, which is bad. So cortisone is good if you're in a real pickle, you have a lot of pain, you're getting ready to go on a trip or something and your knee's bothering you. Cortisone works very, very well. It just doesn't work for, real long. And then the other major type of injection is something like this. This is Synvisc. There's lots of other products like it, Orthovisc, Monovisc, lots of different ones. And this is a lubricant. So in an arthritic knee, the fluid also wears out, and it goes from being a slippery, oily joint fluid to kind of watery. And so if someone's having kind of low-grade daily arthritic pain, we do tend to at least try something like Synvisc. The percentage chance of it helping you is just like glucosamine, actually. It's about 60%. And that means that 60% of people that take it get 6 to 12 months of pain relief, of most of their pain relieved for 6 to 12 months. That's what the study showed. But it's very, very expensive. Cortisone may be a $30 injection plus whatever, the doctor for putting it in. This is $750 to $1,000 depending on your insurance. So it ought to work better than 60% for that price. But I use a lot of it. The third thing is just what I'm going to call a big bucket of small things. For example, there's knee sleeves you can use. If your knee swells, you can use a knee sleeve to keep it from swelling. One of my favorite things is ice packs. Ice is free. It has no side effects and works very, very well to control pain. And so if you predictably have arthritis at a specific time, end of the day, end of your work shift, icing your knee down is just a great way to alleviate pain. Also in that kind of general bucket would be things like weight loss, which is huge, because if you lose 10 pounds and you walk 5,000 steps a day, you're giving your knee a 50,000 pound break each day. So that is one of the most significant things that one can do, is to lose 5 or 10 pounds. So those are a lot of little things. The type of shoes you wear are very, very important. I've gone from wearing leather-soled loafers to wearing a rubber-soled loafer, and that helps my knees tremendously. And then finally, once we've gone through pills, shots, all the other things, braces, ice, over-the-counter medications, changing our shoes, changing the surfaces we walk on, changing the type of exercise we do. Then comes potentially, if your x-ray shows bone arthritis, joint replacement. Joint replacement is not the best term for it. The rest of the world has a different term called total joint arthroplasty. So a rhinoplasty is changing the shape of your nose or doing something to your nose, and arthroplasty is changing the shape of your joint. So you get bow-legged or knock-kneed, you're changing it back to a straight leg, and you do that by resurfacing the bone. So you don't, cut here, and put a machine knee in. You actually are just putting a new surface on the ends of the bones, but you keep all of your ligaments, your bone, your muscles, and tendons. And knee replacement surgery has been around since the 60s, believe it or not. The designs that we're putting in today were invented around the early 90s. So we now have 20-year data on most designs in the knee and the hip. And they last around 20 years, which is incredible. I don't know many artificial things, period, that last 20 years. 95% of people still have them in at 20 years. If they're done well and rehab goes well, that's really, really good. So that is knee replacement. And I'm sure some of you may have had knee replacement. Knee replacement has come a long way in the last even 5 years. My practice, for example, 5 years ago, I did 100% of my patients in the inpatient hospital. And in 2021, I now do less than 50% in the inpatient hospital and greater than 50% in the outpatient surgical center. Approximately 75% of my patients go home on the same day. And that has to do less with, how I make an incision and do this, as it does the type of anesthesia that we use, some pain blocks that we use, some different medications in the knee at the time of surgery. So I did 5 knee replacements this morning at our outpatient surgery center, and they're all gone. They're all at home, and they do very, very well. So that's exciting and new with what's going on with knee replacement. So that was about 12 minutes of just going through the various treatments for osteoarthritis of the knee. So I'm going to pause and just ask if there are any specific questions that I can answer, and I probably will need some help from the Wake Forest team with that perhaps, but I'll do my best.
Okay, and if you all could please submit your questions in the chat box, and or you can take off your video and your mic and ask questions that way as well. So please go ahead and feel free. Okay, it looks like we have a question.
Yes, Julia. I have a question. Good afternoon. I had a knee replacement 14 years ago and on my right knee, and I'm still feeling some pain. So I've heard Dr. Lucey say the way that they do the surgery. So is it possible to still have arthritis in a knee that has a joint replacement?
It's a good question, Julia. The answer is no. So when we cut the ends of the bones off and cap them with metal, the arthritis is cut completely out 100%. It's impossible, actually. You have metal and plastic surfaces, you don't have any arthritis in that knee. The pain can be coming from other sources, but it's not coming from any arthritis.
So we need to go back to my Dr. David. Dr. David Pollock did mine.
Yeah, I know David quite well. He's good. I would just go back and see Dr. Pollock and get an x-ray and have him check it.
Okay, thank you.
You're welcome.
Okay, the next question is, how do you know if it's arthritis or something else?
Yeah, it's also a very good question. So obviously, the only way to really get a diagnosis is to visit with an orthopedic surgeon and let them examine you and take an x-ray. There's plenty of knee diagnoses that I see and treat. And so that, it takes an interaction with a physician, with an orthopedic knee surgeon, and an x-ray to kind of get to the bottom of it.
Okay, next question is, how long does a partial versus full knee replacement last?
Yeah, very, very good question. Very interesting question. A partial knee replacement and a total knee replacement parts themselves actually last about the same length of time. What's different is when you do a partial knee replacement, you're only replacing the inside, the outside, or the kneecap compartment. There's 3 compartments: inside, outside, kneecap. So if you only replace 1 compartment, you still have 2 compartments that are your own, and they can wear out. So what tends to happen sooner than the parts wearing out is actually the other areas of your knee catch up and have arthritis, and you have to convert it to a total knee replacement. So what I do is I use partial knees as a strategy with people in their 50s, where to get them further down the road before we do the total knee. So say 10 or 15 years, and now they're 65 or 70, and we put that first total knee in, which lasts 20, which gets them into their 90s. Or if they only have partial arthritis and they're in their 80s, you can put in a partial and feel pretty confident that it's going to last greater than 10 years, and it's just less surgery, smaller incision, less pain. So it's a good question. They're both excellent operations. They just need to be done in the right patient at the right time.
Okay, from Valerie, I have been told to get a knee replacement, but hesitant. I've heard from people who have had knee replacements to not wait too long. What is waiting too long?
Yeah, so once the knee's worn out and you're limping around and you can't bend and straighten the knee very well, several bad things happen. Number 1, you tend to gain weight. Number 2, you begin to limp, and it hurts your hip and your low back, and you could start to have other problems. Number 3, once you lose range of motion and begin to get weak in that knee, your rehabilitation is going to be a lot more challenging than if you got it done when you still had pretty acceptable strength and range of motion.
Okay. If from Walter, if a typical replacement lasts 20 years, is the next replacement, if needed, any easier or more problematic?
It's far more difficult for both the doctor and the patient. So taking all the metal out that's cemented in, and then you're left with, damaged bone that's kind of not as high quality. It's typically older bone. So the replacement parts in a second time are what we term a revision total knee replacement. The parts are larger. There's lots of what we call augments, where you can put metal blocks and rods and things to help give stability. So it's a more challenging operation for the surgeon. Patients do very well, but the rehab, because the surgery is more challenging, the rehab can be a little more challenging also.
From Karen, what is the recovery time for a knee replacement?
So my typical response to that is to ask the patient, recover to what? Because they typically have something in mind. So in other words, if someone works for you and their drivers getting in and out of a truck all day, if that's what they're referring to, the answer is probably close to 3 months before they can be hopping up and down and out of a truck for 10-hour shifts. Some people have golf as that's what they want to return. Some it's being a secretary. I mean, it just depends on what the end point is. Generally speaking, it requires 3 months of attention. 6 to 12 weeks of formal physical therapy is very, very important. Depending on the patient, 6 to 12 weeks of formal physical therapy, and then a home exercise program for an additional 3 months. If I have secretaries or any desk worker, it could be an attorney, whatever, if they're able to sit down and do their job, they could perhaps get back as soon as 2 weeks. But that doesn't mean they're not in therapy and still, working hard, but they can begin to do their job. But the general answer would probably be 12 weeks.
From Dolores, any interaction with blood pressure / statin meds when getting a knee replacement?
That's a real good question. There's lots of reactions with lots of medications, and we use a lot of them around surgery. And so what we do is we have a very formal process where we have a medical clearance where we interact with your primary care physician to make sure we know what medicines they are, if they're going to interact with anything we're going to give. And then our last kind of line of defense to make sure that the patient safety is preeminent is the anesthesiologist who takes care of you in the operating room. They have their own separate assessment that follows just to make sure that everything that they're giving you and that you're going to be receiving, in the operating room just after surgery works well with your medications.
From Jim, does your BMI have to be below a certain level before you can have knee replacement for us overweight people?
It does. It does. Another good question. The body mass index of 40, there was a study done approximately 8 years ago that showed a 4 to 5 times higher risk of infection, stroke, heart attack, and deaths after joint replacement for body mass index greater than 40. In addition, the ones that didn't have any of those problems, the joint replacement lasted half the time. So somewhere around 8 years. And so it has become very mainstream for insurance not to approve or hospitals not to schedule, and obviously, therefore, the surgeons not schedule patients whose body mass index are greater than 40.
All right, for Mary, what is going on in research to help so surgery is not necessary?
Well, that's a good question, but I will say that the future is now. Knee replacement is a phenomenal operation, 20 years of very highly functional, very low pain living from a knee replacement. So it's just a knee, hip, shoulder, just incredible results. So I don't think, because the human body is created for a lifespan. And so I hate to say it, but once we hit about 30, 35, we begin to degenerate. So if we ask a different question of could someone figure out how to keep the human body from degenerating, then we may stop doing not just replacement surgery, but other surgeries. I just personally don't think that's ever going to happen. So I'm very thankful we know how to do replacements. The stem cells that you hear about, I think, are going to be a really big deal and a huge part of probably the back 5 or 10 years of my career. It won't necessarily prevent surgery or the wearing out, but we may be able to figure out in its early stages how to use stem cell therapy to slow the degenerative process, perhaps. And I think that's about the best we could ask for.
Okay, and from Dolores, do you practice in Winston?
I do not. I am a Greensboro citizen and a Greensboro doc. So I have, again, the hip and shoulder surgeons. They actually come over 2 half days a month to my office. My office is on Wendover Avenue, really pretty much right in front of Cone Hospital. And but my practice is in Greensboro. We have obviously lots of surgeons in Winston, but Wake Forest, as most of you know, just merged with Atrium Health. So that footprint is going to be enormous all across the Carolinas. And so I just happen to be one of the surgeons, and I have an office in Greensboro and in Asheboro.
Okay, we have several more questions, so hopefully we can squeeze them in before it's time. So from Julia, I can feel my hardware and sometimes it doesn't bend properly. What causes that to happen?
Well, I'm assuming she's speaking about a knee replacement, and it really, you really shouldn't be able to feel it, and it should be able to bend well. So I would definitely say go back to your doctor, have an X-ray and an examination.
Okay, the next question is physical therapy helpful in some situations, or is there any good strengthening exercises you would recommend, Wendy?
Basic strength exercises are easy to find on the internet as well as at a local gym or YMCA, and they're all relatively similar and very important. Prior to knee surgery, they're helpful just to be ready for surgery. After surgery, they're absolutely essential.
Okay, from Janice, I'm having an MRI tomorrow on my knee. It is acting just like it did 20+ years ago before surgery for a torn meniscus. Will it work to have the same procedure done again?
Yes. So typically an MRI scan is to look for a meniscus tear or cartilage tear. Most cartilage tears, you have to remove about 10, 20, or 30% of one cartilage. So you still have 70% of one and 100% of the other. It's very possible to tear a different cartilage or the same cartilage in a different location 20 years later. Absolutely.
This one's from Mary. What about stem cell? I think it's in reference to, I guess, the knee replacement.
Yeah, again, I think stem cells are going to be wonderful. I actually have done it. I've been on some of the national research in that, and I'll try to explain it briefly since we don't have a lot of time. But the stem cells that we used in the study, and what I think are the best source of stem cells, is actually the placental tissue and the amniotic fluid from a healthy mother who gives birth to a healthy baby. And then they no longer obviously need the placenta or that fluid that the baby has been bathed in, the amniotic fluid. And so that's where we would get the cells, and we would use that placental tissue or the fluid. And what we did was we injected that fluid into knees. And you can imagine that if a baby has been swimming in that for 9 months and growing, and mom's probably been exposed to pollutants and the cold or COVID, who knows what. There's incredible anti-inflammatory properties there. There's incredible growth factor there. And so that's where I see us using it in the knee, would be as a very safe, very effective, longer term injection than either the cortisone or the lubricant that I mentioned earlier. So very exciting stuff. I don't think at the end of the day it's going to make it where we don't have to do knee replacements.
All right, and last question. What is the chance of getting an infection when having a knee replacement? So
the chance currently in the data from the last couple of years is that it's somewhere around 0.5%. So about 1 in 200, if that makes sense. So it's very, very low. The key to that is having a surgeon that does a lot of them, so that the surgery doesn't take that long and is not open to the environment that long, even though the operating rooms are obviously quite clean. The length of surgery correlates to the risk of infection. So a doctor, anybody that does a lot of something, they get very proficient at it, and it doesn't take very long. And so when we see infections, it's typically in doctors that maybe don't do a whole lot of knee replacements or hip replacements or whatever surgery we're talking about. So that to me is one of the biggest keys to not get an infection, is to go to a doctor that does a lot of them.
And that's all the questions.
Super. Good questions.
Thank you for your time.
Yes, thank you, everyone. Have a good evening.
Thank you.